So as Maurice explained, what we are doing is I'm very conscious at this time of the day that people may have to leave or only be part of the session for an hour. So it is going to be recorded, so it will be available for anyone who's in attendance to, if you need to leave earlier, text children, it is going to be there. Everyone is identity is what's called, you're not on video, you are muted, as Maria said, so please engage with the chat function, be that a comment, a question, and throughout the event, Maria and Elaine Burns are actually going to collate and thematic those questions, and towards the end of this hour, we'll actually try and address a number of them. Some of them we may not get an opportunity to address, but we will respond to them following this WebEx. If the, what to call it, I'm just checking their seats, I just, Bernard was to commence. Bernard on there? No, not as yet. Okay, so what I'm going to do is, the idea of today is, Laura, I'll continue with this, and when Bernard joins, then I'll revert back to him. That's okay. So what we had was the CEO looked for an engagement event. So he went to both the RIOs to look for staff engagement across primary care, disability and our CAMS teams to look at regarding children disability services, and he also engaged with our family forums. So that engagement took place over the months of April and May. And what the CEO agreed to do was, following those engagements, that there would be a now and the next. And that is what today's event is, the 16th of June, what we've done so far, what we've heard from it, and the key themes regarding it. Move on there, Laura.
I think Bernard has just joined.
Brilliant. Okay, that's great. Bernard, I just was doing the introduction there, so and just explaining the context to this event, so I'll hand over to you.
Okay, thanks very much, everybody, and you are welcome. I think I'm told there's about 70 people joining us for this part, so I hope that everybody did manage to get on. And as Aoife said, I mean, essentially, this is about feeding back, as it were, from what I've heard from people, and so we have. Have you shown the agenda for this morning, Aoife? Sorry.
No, not yet. I just said I'd let you open it now.
Yeah, so so essentially this is about feeding back. It is an hour, so I'm conscious an hour can appear like a long time, but it can also then be a tight time when it gets into some of the details. So I've asked that the component parts of the agenda that they're worked through in a timely manner, and then closer to the end I'm going to give you some more detailed feedback on what it is I took from what you said to me and what it is I believe I can do something about right now and in the coming months, as distinct from off out in the distant future when a lot of the more significant reform needs to happen. Okay, Aoife.
So the plan for today is we'll have a number of kind of presentations. The first one is I'm going to go through the key themes that have actually come up from our engagements with both staff and ye as family reps. And as you can appreciate, with some individual topics that were discussed and themes, we've collated them into a number of themes. Following that, then we're going to discuss the single point of access. And the idea of this is that as parents, it was clearly articulated that at times you have to send a referral to access our service to many different points. So there'll be a presentation on the single point of access and what that looks like. We then will also have a presentation from Mary Doran regarding recruitment and retention. We will have an update from Anne Burke regarding the roadmap and what has done and the actions to date. And also then St. Gabriel's, there was a project there, which is a collation between national disability, local disability in the States about progressing the scope and specific purpose CDNT, which will open in Q1 2027. And it's about everyone working in collaboration and partnership together. Then there will be a piece, as Bernard alluded to there, regarding now and next, and we'll have some discussion on questions. So it is there's a lot in the agenda, but we do want to maximise the 60 minutes, give you as much information as we can. And again, as discussed earlier, please put any comments, suggestions or questions into the chat function. Thanks, Laura, for sharing that, and we'll go back to the PowerPoint presentation. So as I discussed, for some of the family reps, you were engaged, you were involved in them, and some couldn't attend. So those 3 questions that were asked by Bernard, our CEO, regarding the Children Disability Services, just the next slide there, Laura. What is working well? what are the challenges and what can we do about it? And the 3 questions then came into certain themes. So the first one that has come up really strongly is a referral pathway, and I'll discuss that theme. The second one then is the care coordination, where it came to a child and the amount of work that carers as a parent as EE had to do to coordinate that. So we'll be examining the role of the key worker, also the use of technology. And parents gave real examples of the use of technology and how it can support them in supporting their child, maximising their potential. There was also the whole area of community innovations and projects that worked well with our staff, and then the importance of that interdisciplinary working and interdepartmental working. So our first piece that we're going to look at is the single point of access. And regarding the single point of access, we will have a presentation on it, but the idea is that if someone needs access to a disability service or our children's services, it'll be one single point of referral. So if the child may need support from our CAMS team and our CD&T team, that they go through one single point, and that is the access. The other thing is that this is collated to a central referral office in each of our IHAs. So there's a number of different projects that have happened throughout the country, but we will collate the knowledge, the information, and ensuring that that is actually implemented by Q4 of 2025. The other thing we're looking at is regarding our waiting lists, and there's a lot of discussion of children waiting on waiting lists, and a number of you parents stated that whole window of opportunity, the loss of that window of opportunity. So what we're looking at doing is actually having a performance call. So that will be a weekly call led by Bernard Gloucester, our CEO, reviewing actually what is the week-by-week progress regarding waiting lists. That's including all our children teams with a focus on ensuring that children are seen in a very timely manner, and as well as looking at assessments, the ultimate importance also of looking at intervention and support for those families. The next piece then was, as we discussed and reviewed the PDS model, many related to the benefit that they had seen and had taken from early intervention. So we're engaging with one of our Section 38 agencies about a pilot project which will see the development of a nurse-led support across 3 of our CD&Ts that will enhance and develop that early intervention model. So that need to support parents during those critical ages when the child is under 6, but it's not to take from our primary care CAMS or disability teams, it's to work there to enhance, to support parents with critical support regarding what can be done. The other thing then regarding our AON, as many can appreciate, there's a lot of work being done regarding it to look at our systems, our standard operation procedures. We'll also have 2 of our national staff taking a look at it from a quality initiative perspective to see actually how can we work on progressing it, making it more efficient and making more timeline. And we also have ongoing engagements with Destiny regarding it. We will be hosting a webinar also between now and September on AON and just giving further feedback because it is an area that needs a little bit more discussion. Following that, we've looked at the role of the key worker, and many of you parents did allude to the importance of the key worker where it was available, how there was one single point of contact, that person coordinated care, with a commitment from our CEO, Bernard, that we will put in an ask to estimates regarding that key worker. So that's a key role that we heard from you was really good. And we also hope that this person would assist in allowing therapists access to more clinical time and more intervention by them being able to coordinate the support, the questions and queries, and ultimately provide a better quality and higher quality service to you as a family. Administration resources as well. Bernard has given commitment to review the administration resource and actually how can that benefit time for both the CD&Ts and also our other clinical teams supporting children. So if that admin resource was available to teams, how would it ensure that our clinicians are better utilising their knowledge and skills and interjecting and engaging with these families? We've also looked at parent gave a really good example about a video that was done with her in a session with an SLT. The video was given to her straight away after the session. She went home, she was able to look at that video and support her child regarding communication session. As opposed to a similar session she had to wait over 2 weeks, the documentation was late coming to her and she was unable to implement what she learned at that session and what her child learned at that session. So we're looking at the benefit that can be done regarding the videoing of sessions, the use of video sessions for parents and families to support, but ultimately to enhance that clinical experience. The other ask has been regarding the use of social stories and visual tours of our building, a really well-made point. and a point in order to prepare our children as they enter into our buildings. So there is ongoing engagement across both CD&T, primary care, and CAMHS regarding how we can do this in the visual tours, so that children can be really well prepared coming into these appointments. We all know the benefit of it, but that is happening. Access to medication as well has come up, so we are engaging with our teams in CAMHS. And again, that need for, instead of having to make a new referral, if there's a need for a child who is in a CD&T team to access CAMHS, that it's done in a timely way, and that we support that access to the CAMHS team regarding that medication. We heard that quite strongly at a number of our family engagements. Regarding respite, it was evident that we don't have a national pathway or an understanding from parents regarding how to access respite, and at times they have to do a referral to many different service providers. So we've looked at respite and tried to stand up as much as we can, especially coming into the summer months, which can be a time which is a need for enhanced respite from all options. So we have a service in Sligo that had funding for a 5/7 for a respite service for children with varying complex needs, that we have been able now to secure funding for that for 7/7. So the hope is that that service will open in August, September. It's based on the Pierce Road in Sligo. It'll be providing for 4 children overnight respite, but as well as enhancing the respite for those children, it will also increase capacity for adult services, because the model is currently a shared model where adult and children go into the same location, obviously at different times. But by children having their own standalone service, this will give access to increased respite for adults. Also addressing the need for when your child is coming out of a respite centre and they're turning 18, the onward path regarding it. Very positive initiative. We've also engaged with the team in Cork regarding Horizon. There was a requirement there regarding posts, so we've been able to address that, and we're hoping to have those services again stood up in August, September. They're in active recruitment. It's centre-based respite, but there's also a number of varying models that will be added to it. We've a respite paper that has been concluded with the department, and there is a need for a strategic direction regarding respite, the standardisation and a uniformed approach, so there's a multitude of options available for respite, be that in-home support, after-school clubs, summer camps. And in line with that, we've engaged directly with the GA. So over 2025 in the summer, there'll be 40 accessible camps available for children who have complex disability needs nationally. So we're engaging with the GA to support them on those. But we also have been asking regarding the access to the mainstream GA camps. So there's ongoing engagements regarding that enhanced experience for children who can access the mainstream camp, who may need additional support. So some of these children will have SNA support in school. So that has progressed extremely well. And it's a project that we hope to see advancing in many other ways in the next coming months. In order for the child to have an enhanced experience is absolutely critical and a forefront. But we also want the additional piece of the trainers, the coaches that are actually engaging and presenting in these GA Cool camps to have that knowledge and understanding of disability. We are also going to host a webinar on respite options. So that respite is quite complex about the projects that are there, the initiatives we're doing, and how we hope to build and grow that capacity for respite over the coming weeks and months. But it is a key priority of ours in the National Office to support all the local initiatives that are happening and ultimately enhance the opportunity for respite for children. The other piece that was heard quite a lot in many of our engagements was the need to balance the role of this family-centred practice and that need as a family to be the coordinator. So we're hoping that the role of the key worker will have a key aim at supporting that. But we also have a Parent Connect project that was done across 3 counties in Ireland. So there was one done in Cork, one in Tipperary and one in Galway City. It was a collaboration between NUI Galway and Enable Ireland. And what it saw was that the parents became a support to new parents coming into the CD&T. As many people can appreciate, it can be quite challenging, all the new terminology, all the new processes, and even an understanding of the model. So to be that peer-to-peer support, Enable Ireland are going to launch it tomorrow in NUI Galway, so we need to commend them for that work. But anyone who has participated, either being a supportive parent in the process or being a recipient of that support, the evaluation is really positive. So we're going to look at now the rolling out of that further across our CD&Ts, especially for the support for those new parents that say join us. Move on there, Laura, now. The other piece was family forms. There was mixed feedback regarding family forms, but what we have is there's some of them that are working very effectively And there's some key elements of why they have worked so effectively for the parents. They see it as a huge support. So what we want to do is grow that good practice and develop it and support other family forms with that peer-to-peer support. The need for satellite clinics, many parents spoke about, especially from the west of Ireland, Cork and Kerry, and having to travel all the way up to Dublin for a multitude of appointments. So we're engaging with a number of different providers about the establishment of clinical hubs. And one area that we've had a lot of feedback on is regarding with Cerebral Palsy Ireland, around the need for enhanced support for the child with a physical disability and how we can actually coordinate that, bring it closer to the local team. So there's really good engagement, including last Friday, regarding what that looks like. Along with that, we're looking at a clinical pathway to support these children. So not only children with cerebral palsy, but all the children who have that physical disability, the need for seating, for communication and complex support. We also have engaged with Enable Ireland, who had a business case in the system for a number of years, about expanding their seating clinic. So for any of you as parents who are supporting a child who needs wheelchair specialised seating and moulded seating, it can take a number of appointments before that chair is actually received, and a lot of time away from school and away from home. So it's about trying to get these seating clinics as close to home as possible for you to be able to engage directly with, and if there's issues with the seating. So Enable Ireland are in an active process of recruitment, and we'll have further updates in the coming weeks on that. So another really good project about bringing resources as close to the child as possible. And the parents and sibling well-being, as well as the child being front and centre, we all are very consciously aware of the need to support you as parents and the siblings of these children. So we've engaged regarding the support that we can offer, and we have a number of initiatives that we will be bringing to you as parents to see your suggestions and ideas regarding it. The next one, Laura. The other thing is we had really good feedback regarding our South Hill team. So that is a project that St. Gabriel's will actually be presenting to you today, and we have a video on that. We also had an issue regarding the lease of a building, CH07, and I can give assurances now that the IHA manager and the head of disability is about that issue is to be resolved, with hopefully the co-location of one of our Section 39 agencies alongside primary care. And that was commended a number of times about the importance of that. So they'll be going into the ground floor location in primary care on the upper floor. So another positive initiative, and hopefully that issue that was raised in May will now be resolved with moving in July. Accessibility of our buildings, there is still a number of issues regarding some of our buildings who are not on bus routes. So we've ongoing work to do on that, but some of our other buildings who need to ensure access, and where there has been some minor issues, we've been able to address it. Access to technology. So access to equipment is being addressed. There has been a number of issues regarding reps and access to reps, but regarding access to tablets, we are looking at that and giving timely access to children to the tablets, as well as access to those really important apps and the guidance and support that parents need to support the child with them. And then the digital technology, we have an ongoing project with WHO regarding actually looking at how can assistive technology not only help us in the HSE from a clinical perspective and a support perspective, but help the child regarding their social engagement, their educational engagement, and every element that we can utilise assistive technology to enhance the service experience. Thanks, Laura. And then finally, we have done as much as we can regarding communication, and that everyone knows we can't do enough to actually support communication. So Anne and Ben will be going into that in a little bit more detail. And one thing that has been asked for is dedicated time for our CDNM. So we heard across our 93 teams, there was one or two CDNMs who've been very innovative at how they respond and give parents that time. Parents do not want to have to send endless emails, phone calls, chasing and not getting response. So we're engaging with our CDNMs regarding how can that be done in an effective and a responsive way, and that parents feel heard and have the opportunity to engage with the CDNM, appreciating their caseload and the workload, but that importance of someone returning a call and engaging directly with parents. Also, the voice of the child is critical. The co-design and co-creation of services is important as we engage with their parents, but also as the children who wish to engage and see how can we do services better, what the experience that works, and how can we improve that. So we're engaging with the patient engagement cohort of the HSE regarding that voice of the child and how we include it going forward in any new future developments. Thanks, Laura. And then finally on posts, and there was a number of issues throughout the country regarding posts that had been held that need to be progressed. Some senior posts we heard from both staff and from families, so we've been able to progress them with Mary Doran support. We will see the development of 20 senior posts, 20 basic grades posts into the system in 2025. Their allocations have gone out to all the RIOs with a time-bound limit of 3 months, where they need to have really, really good progress on the recruitment of those posts so that we see them actually delivering services to children this year. We also have looked at the enhancement of the health and social care assistants. We heard very strongly that we don't need the psychologist to be the key worker, but the actual benefit of health and social care assistants in supporting the child and supporting the family. So we'll have 45 of these posts coming into the system in 2025. And again, they're time limited with recruitment, that there has to be active recruitment over the next 3 months. And then we also have been able to engage with 15 trainee psychologists. We've done the allocation based on population health. So those 15 trainee psychologists will be engaging in different teams right across the country to support and enhance the experience of our teams. So at this point, I am now going to hand over to the single point of access, and we're going to have what we've done regarding this presentation. Oh, sorry, I'll just departmental it. I'll mention that later, Laura, that's okay. What we've done is we heard across our engagements about a number of engagements that were working really well regarding single point of access. So we have CHO 8, CHO 9, and then we also had our staff in CAMS working on the single point of access. But what we've done is try to collate that information. I'm very thankful to Michelle Howard and Niamh Clark, who are going to present today on this presentation, but they've taken the learning, the information on it from the other teams. I'll hand over to Niamh and Michelle. Thank you very much.
Thanks, Aoife. Good afternoon, everyone. Niamh and I are delighted to have the opportunity to share with you this project on single point of access. But as Aoife said, it's collated based on our learnings from our colleagues who are also working on this area throughout the country. We can move on to the next slide. Thanks, Laura. I'm going to very briefly just speak a little bit about the approach that we used for this project, which worked across the three care groups, disabilities, mental health, and primary care, to look further, I suppose, at this problem space and to test solutions. And from that, then we, I suppose, design principles for how the solution can be implemented on a larger scale. So we can move on from the next few slides. I think this just shows really that the approach that we took, really, we acknowledge that this is not an easy problem to get a solution for. There's lots of different perspectives and needs. So we adopted what's known as a human-centered design approach, which aligns with the action plan for designing better public services. And if we move on to the next slide, I think, the question that we sought to answer was, how might we optimize existing resources to create an equitable, streamlined, family-centered referral process, ensuring timely access, clear communication, and seamless clinician collaboration. Thanks, Laura. So this approach, human-centered design, it's an approach that starts with the users. So in this situation, starting with parents, families, and the frontline clinicians who are really engaged in this area on a daily basis. And when we use this approach, we view the systems in the context of each other and bring them together to design together. So we brought together the service users, clinicians, managers from disabilities, mental health, and primary care. We use this phrase bias towards action because when we use human-centered design methodology, rather than spending a lot of time in that, I suppose, planning stage, we research the challenges and problems, but we move very quickly towards designing solutions that can be tested with the understanding that is by testing our solutions that we can really challenge assumptions about what will or won't work and then be prepared to make the changes that are needed. Thanks, Laura. So just very high level, this is the background to the project. We worked across 6 months of last year. Again, it was important that it was time bound, moving from looking at the problem space right through to having solutions that were tested that we can learn from. We worked across the 6 counties of CHO8 and the 3 care groups working together, disabilities, mental health, and primary care. And I suppose that was under the understanding that for it to work anywhere, it has to work everywhere. This is a broad project that looked across children's services. And we had 6 recommendations related to 6 different areas. But for the purpose of today, Niamh is going to take you through the area that looked at that single point of access and processing referrals.
Thanks, Michelle, and thank you to everybody on the call. So just to give an example of just how important everybody is in this process, there are 140 service users from CDNTs, Enable Ireland, CAMHS and primary care, and frontline staff, because they often have means and mechanisms along with the parents. They're the two key sources that they know how to solve problems, but we needed the buy-in from the service managers across the 3 care groups, and the support team is IT, the IHA managers. So 371 people were consulted on this single point of access. So next slide, thanks Laura. So just to show you Discover, because sometimes when we think we know everybody's problem, but until you ask the service user, till you ask the young people themselves and their parents, you may have a skewed representation of the problem. So who are we designing this for? Who else has this problem and what else has been done? So what we realized then, that while this is a problem for CDNT, it's also a problem for primary care, and it's also a problem for mental health. And parents were absolutely exacerbated and frustrated with the system, where they had to make multiple referrals. So we ask, we listen, we empathize, and then we design. So that's known as the discovery phase. Thanks, Laura. So we define, so from our definition, the lived experience for families in CHO8 and former CHO8, so that's Longford, Westmeath, Laois, Shoffley, Loudmead, was a challenging space where parents were saying it's long wait list, referral acceptance, assessment, interventions, all of this takes time, and parents were saying we haven't got time, our children need to be seen sooner rather than later. The issues with the referral process came over and over and over again. And as a result, as Michelle said, our colleagues on the call, Olive and CAMHS and Donan and so on, they were doing something similar. We just presented this one today. It was disjointed for parents and there was a lack of shared working. So this is what we did in this one example. We wanted to optimize existing resources because we know we can't give resources to everything. And we had multiple teams processing referrals. We needed it to be equitable and streamlined. So some parents, you know, were fortunate, or were they even fortunate to get a response within 2 weeks, and others were waiting 2 months and 3 months. We needed it equitable. We need families right at the centre, timely access, clear communication, because sometimes even when they got a letter saying they were accepted to a team, they didn't know what team and where and who they could contact. And then we needed the clinicians behind the scenes to work seamlessly with one another to make the journey for the parents easier. Thank you, Laura. So the key principles: 1 referral pathway for the service user. Clinicians process the referral, and only 2 clinicians, and I'll look at this. The paper referral is jointly reviewed by 2 clinicians, one from CDNT and one from primary care, as opposed to multiple teams all reviewing independently and then saying not for I for the other. We're not knowing what the other team were going to do. We needed there to be a shared record of attendance so that parents knew where they were going, what they were doing, the clear communication, and for universal information to be readily available from the get-go. The moment the referral came in, parents needed to receive information, and a process that was easily for the service user to communicate with and the clinicians to communicate to the parent. Thanks, Laura. So the design referral process, what emerged then was, instead of all teams working separately on the referral process, in County Longford, all referrals went to one location. At that point, any child who needed 2 disciplines or more, their referrals were put to one side at that moment in time. And each week, a referral process meeting took place where a clinician from CDNT, an experienced clinician, and an experienced clinician from primary care met, reviewed the referrals, and made a decision there and then. If there wasn't enough material or information on the NAP referral form or the AAF, that child was then called within the same week into an Eyes on the Child called ITIG, and a decision was made there and then. We have a loop in and out to CAMHS. So if CAMHS decided that they needed to loop into the central referral system, we had an undertaking that they would bring children forward to this. And if when the 2 clinicians looked at the referral and said, actually, we think we need CAMHS, CAMHS had a loop back out. In this situation, then, it meant that parents knew within 9 working days exactly what team had accepted their child. Also, the 3 reasons identified on the referral form, on the NAP form, information, reading material, sources, website, locations, all was listed for that parent so that they had information from the get-go. And this resulted in clinicians' time being reduced and more available, reduced for reviewing referrals and more available for providing the intervention and assessment. So the closing remarks: all children in Longford have the exact same access to the referral source. There's integrated working between primary care, disabilities and mental health. And this ensures that children are accessing service at the right time and the right place. Thank you.
Michelle Neal, thank you for that. And it's a synopsis of the approach, but it's something that will be implemented, and Bernard Glasser has been very clear, and he'll discuss that later on in the call. I'd like now to introduce Mary Doran, who's our Assistant National Director for Workforce working in the National Office. Thanks, Mary.
Hi everybody. So I am the Disability Workforce Lead for the HSE, and my job is to bring the disability services across the HSE, the Section 38s and the 39s up to their funded levels. Disabilities is the only care group that has a resourcing lead from that perspective, and in finance and estates we have it as well. Particular focus of my job is Children's Disability Network teams, and I'm going to talk to you about the work underway and where we're going with that work in the next year. So first of all, I'm going to update on the current status of the workforce, and what I'm going to talk about is the growth that we've had. Obviously there is still a significant amount of unmet need, and I'm going to refer to that as well with regards to the vacancy levels. But you know, we are going in the right direction, but you'll see the level of vacancies as well. That is built on the initiatives and the impact that those initiatives have had in 2024 and in the year 25 to date. You'll see where we're going for the rest of 25 and the planned impact of those, and then particular workforce actions that are specifically to do with Children's Disability Network teams. So just looking at Children's Disability Network teams. Now, what I'm going to do, I'm going to show you a graph on the growth. Again, I just like to highlight that I'm really aware that there's a large amount of unmet need out there. So that's something that has got a lot of work going into it at the moment. So as you can see, in where we were in October 21, October 23, October 24, we began to see some growth. And there used to be a yearly workforce report. We've now changed that to 6 monthly, and we would hope to increase it further again. So we always get our finger on the pulse with regards to where the workforce is at and where we need it to be, where we need to put our focus into. So you can see here that in April 25, we've had an increase again. We are funded at the moment for almost 2,500 whole-time equivalent posts within Children's Disability Network teams, and that's part of what our funded base is for them. You know, there is other work going on to see what is our actual need with regards to the workforce, but that's what we can recruit to at the moment. What I would like to say to you, the good news is we have a net increase of 414 staff in the last 18 months. That's really good news. That means after all of the recruitment that's taken place, all of the movement, we still have an additional 414 staff, 0.5, working in Children's Disability Network teams across the 93 teams. So just looking at where we still have a lot of vacancy levels. In October 23, which is kind of the baseline that I go from, we did 29% vacancy rate in the Children's Disability Network teams. We've managed to reduce that vacancy rate by 11% in the last 18 months. That's based on the increase in our funded level coming up. So even though we've reduced it by that, you can actually see that we've an extra 414 staff. But that just shows that we're going the right way with regards to our workforce growth. You can go to the next slide there, please. So how did we do that? How did we actually achieve that workforce growth in the last 18 months? Well, a big focus in 24 and 25 was actually on maximising the recruitment potential and the engagement to achieve workforce growth. So we had really strong focus on having a partnership approach with the HSE-led teams, the Section 39 and the Section 38-led teams. And we dovetailed a lot of our efforts together, because the truth is we're actually recruiting from the same pool of people. So we need to have a way of really optimizing how we recruit from them, so there isn't a lot of robbing from Peter to pay Paul. There was really intense recruitment efforts across the HSE and across our funded agencies. Another thing that we did is we looked at how can we increase the potential for the different agencies to recruit. So within the HSE, we have a mass intake of the new grad panels coming onto our national panels. The HSE is really substantial presence when it comes to advertising and when it comes to international recognition as well. So what we arrange is we've arranged for our Section 38s and our 39s to have access to our HSE panels, access to our HSE website, access to our Career Hub. Now, just to say, Career Hub is 47,000 registrants on it. Everybody who's interested in working in health and social care in Ireland and is available to work is pretty much registered with those. And a lot of our international market is as well. And some of the agencies have been reporting that there has been a marked increase in the number of relevant applicants to them, which is really good. The other thing that we did in line with our roadmap action was in April this year, we launched our first Children's Disability Network team under our postgrad sponsorship. So this has been launched, and what that is doing is job matching into OT, SLT, physio and social work. Those new grads coming out, we're job matching them into jobs in Children's Disability Network teams, and we did a webinar on that as well, and that was really positive. So that's part of what you can see, and that's just the flyer that went out to all of the colleges, and we chased up with them, and we can see that a person from every relevant course has registered for the new grad sponsorship, which is great. So the next slide there. So what are we moving forward with? So as I said, we really focused in the last year in optimizing the current market. What we're really trying to do now is build our pipelines, build the people to come in. A lot of that is about improving the perception of working in Children's Disability Network teams and in wider disabilities. And we had a huge amount of engagement across the secondary schools, colleges, international applicants. And we had our first virtual career fair, which took place in May, and that particularly featured CDNTs. It also featured primary care, CAMS, so every service that supports a child, it featured those services particularly. We also reach out into public events such as the National Ploughing. So Children's Disability Network teams are spotlighted at all of these. And we created a lot of online content together with the Section 38s and 39s to engage applicant pools and to bolster our recruitment effort. Like, we've fantastic content out there. And what we do is we encourage any recruiter to take some of those videos, attach them to their recruitment campaigns, attach them to their job offers, because they tell a much better story than an email will offering a job. We're also looking at the development of disciplines. We already developed the therapy assistant discipline that was delivered in 2024. And this year we're looking at the behavioural therapist. The truth is there's a global shortage of healthcare workers. So we need to look at how we can diversify our workforce to support children with disabilities and their families. We also developed a bespoke recruitment pathway for chronically unable to fill posts. So these are posts that we tried again and again to recruit. And now those posts are always advertised, and we've had some small success in filling those, which is really good because, for example, there was one particular team that had no OT. They now have an OT on foot of this. So there's no one answer. It's these layering effect of the multiple concurrent initiatives that really make a difference. So just going on to the next slide. So that's a picture, for example, of the webinar that was held. I can go to the next one. And that's a picture of content on the Career Hub, and going to the next one. So what we did, talking about developing a lot of content, that's Enable Ireland and that's St. Michael's House. And that's the content that goes with the therapy assistant campaign. So every time these are advertised, we include that content with it. And that really encourages people because it's much easier for people to see what the job does rather than read it on a job spec. And next one there, and next one. Great, okay. So looking at talent attraction, we always make sure that disabilities is at the forefront for any of our engagement in 2025. And on the left there is a list of engagement or outreach where disabilities and Children's Disability Network teams are represented. And in many of those, all of the care groups that support children with disabilities are represented. So that's a really important part. And I think it's important for you to understand the level of engagement that's happening with potential applicant pools. So the next slide. So looking at our actions and our planned impacts, well, the main areas that we need to hit are growth. That's a focus on the high vacancies Children's Disability Network teams. I've alluded to the fact that we've reduced the vacancy level. It's not 18% in every team. Some teams have much lower percentages of vacancy, some have much, much higher. With regards to the pipeline, what are we doing to always ensure that we have a sufficient workforce available to us? I'll also refer to the recruitment journey and just looking at retention then. So what is important and why? So just looking at 25 and 26 where we're going. So in 26 and for the rest of 25, a big focus is about increasing the pipeline. And this always needs to be co-designed and co-delivered with the health regions and with the funded agencies. So as I said, we've already launched the 2025 first ever sponsorship for CDNTs. We're looking to make that bigger again for 2026, funding dependent. And that would be to sponsor them in their last 2 years of their training, funding dependent. And there is apprenticeships models being developed as part of the HSE. These are being further developed specifically for Children's Disability Network teams, and I'll be updating you on this as the year goes on. We've already increased clinical placements on 30% in the past 2 years, and we're looking for increased growth in that again. The programme for government puts in additional health and social care professional training places, and there's going to be 320 additional places in 25 and 140 in the subsequent years, and that's across dietitian, physio, OT, SLT and social work. They are not all for disabilities, they're not all for children's disability teams, they're for across the health and social care network, but we will be able to recruit some of those people into our teams. Again, we'll work further on diversifying our workforce, and a big element is the rotation into other care groups. Many in our Children's Disability Network teams, many of the roles are at a senior level, so we need to make sure that we build rotations going out into primary care, CAMS, and that serves everybody, because then the child gets a more holistic experience with regards to the intervention. So just go into the next slide. So what do we need to deliver? A big element is the co-design and co-delivery with the health regions and funded agencies. We've seen already from the presentation today this fantastic practice in pockets. We need to upscale that practice and then deliver it across them. To scale up the clinical placements, and as part of our request into the government, that includes in it, we need to build a rotational infrastructure that works for all services that provide care for children with disabilities. And we need to have space for growth within our agreed pay number strategy. And we also need a funded pipeline initiative through all of those. So just look, specific things that came up in the meeting with the CEO and the parents, with the people on this call, is to identify main obstacles. These are the internal and external obstacles that lead to high vacancy CDNTs. I'm currently working on that with specific CDNTs. There are some really what I would call high staffing teams. They have very low vacancy rates. What are they doing? What can we learn from them and bring them into the high vacancy CDNTs? One of the elements we'll be looking at and progressing on a pilot basis already is how we work through assisted recruitment and to review. We always need to review and respond. And just on the final one, I know that the time is up, so I'm going to go straight through to just on retention element of it. Okay, so just looking at retention, we do know, I know this is really important, a lot of parents have brought this up, retention is most important. To keep our staff, our committed staff that know your children, that's the most important element. Financial incentives have a really high impact on recruitment. They have a very reduced impact on retention. We know what the main factors are, and we're working forward and putting in forward a recruitment strategy and retention strategy and retention plan to address any recruitment and retention issues that we have. So thank you very much. I hope I've addressed most of them.
Mary, thank you very much for that very comprehensive update, and there's lots of different initiatives, which is very clear from that presentation happening. I'm going to hand over now to Anne Burke, who's been the lead for the Roadmap for Children since the 23rd of October 2023 when it was launched. Thanks, Anne.
Thanks, Aoife. So starting out, you all will have received the report, the Q1 report, I hope by now, that was sent out to family representative group members. So you'll know that out of the 60 roadmap actions, 18 have been achieved to date, and then we've a further 11 are in place and ongoing. They don't have an endpoint. We have 23, as you'll know from that report, in train for delivery this year. The first one there, the revised HSE TUSLA joint protocol. So this was launched in 2017 with a review in 2020 that brought in the acute services component, and it is now currently being reviewed over the last year. A significant level of consultation has taken place across HSE and TUSLA staff, and it is now in its final round of consultations with an anticipated final date for delivery of the updated joint protocol this summer. Under service access and improvement, we've a number of items in train for delivery in the coming months. The first, welcome packs for newly referred children to all CDNTs. I can say as of this morning, all CDNTs now have a welcome pack in place for all new children referred to their teams. We will work under the comms plan, which is I'll cover later. We will work to standardise the content of those welcome packs, but our first goal was to get one in place across all CDNTs for new children. Under the Aids and Appliances Review, which Aoife mentioned earlier, the review is ongoing under a WHO global initiative, and we were very, very happy for Ireland to piggyback on this global initiative. So under the WHO, in the Q4 of last year and Q1, January to March this year, extensive consultations were completed across all service providers via interviews and online surveys. A workshop on WHO's draft findings and recommendations was delivered via the Department of Children in May, and it is now on schedule for a final report to government this summer. And you'll know from the roadmap that the Aids and Appliances Review, it has a focus to standardise access and consistency of what is available for all children and adults, indeed, across the country. We also have an annual survey of privately commissioned services in train at the moment to support waitlisted children and families. So again, this is a roadmap action that we know is in place and ongoing, but we want to find the level of privately services commissioned privately, I should say. So this is in tandem with all of the actions that Mary talked about as we fill our teams and we provide negotiate with government for additional resources to meet the growing demand for children's services. We also are commissioning as much as possible private services to support waitlisted children. That survey will be due in on the 30th of June. The Disabilities Capital Plan is in development with a particular focus on CD&T accommodation gaps. We know to provide authentic child and family centred services, all staff members of the team need to be in one place. And many teams have gotten their co-location now of staff members, and it works particularly well where they're co-located with primary care from a family's perspective and from a staff's perspective. So that's what we're working on, and that plan will be in place by the end of this year for the remaining teams that are not currently co-located. April data shows us that children's waiting lists, the CD&T waiting lists, have decreased a total of 2,058 children over the past 6 months. And this, at the same time, in the 6 months, it's worth noting that we had 5,267 new children referred to the teams. So the waiting lists are going in the right direction. We appreciate it's not fast enough, and we are working on increasing that. At the end of April, the number of children waitlisted for CD&Ts sat at 11,447, and that is a reduction from the 16,552 children in June 2023. In April, it's also worth noting that 1,632 waitlisted children and their families received one or more supports from the teams. And that is up 73% from the 942 children waitlisted in October who received supports while they're waiting to be on board onto the CD&T. Slide is in there. Under technology, we're doing a survey of CDNMs on their team's current use of digital supports. We know that during COVID, this was very popular and very well received with families. And recently, anecdotally, CDNMs are advising that it's not as popular. However, we want to ensure that there are similar practices across all teams. So we're surveying the current use of digital supports across all 93 teams and all 12 lead agencies. We want to use that information then, first of all, to share it across the teams and to work towards the standardization of digital supports. And also we are asking CDNMs and their teams to identify if there are additional digital tools and processes that would enable them to further enhance their online service provision where appropriate, and of course where families want it. And we will do that, we will use that information then to see what else we can develop and standardize across all teams. The Children's Disability Network Team Information Management System is in place for all HSE-led teams at this time, and it will conclude full migration for all teams by the end of this year. That will help to automate our data collection and again, refocus staff as much as possible for delivery of interventions. Under staff retention and attraction to CD&T services and also service access and improvement, the NDA review is now in train. It's in two parts. The first part is looking at the CD&T child and family centred model in operation, the 12 principles, what's working well, what's not working so well, and what the solutions to address those are. Part two is to identify optimal staff workload and team configuration. So what disciplines do we need? What competencies do those staff need on the team? How many we need in order to address the current demand and to maximise efficiencies and effectiveness across all 93 teams. It's in train, it's a tripartite approach where online surveys are in train at the moment, focus groups and individual interviews are also taking place. It is on target for delivery at the end of this year. The NDA hopes to have an interim short high-level report in the middle of the summer to support us in our estimates process for 2026 resources. The recommendations, as they will form the estimates process. And finally, under communications, we've developed an extensive communications action plan with our roadmap parents. This is now approved by the Service Improvement Programme Board. It includes significant supports to be developed at local and regional and national level to support consistent, transparent and regular and frank communications with our families and our staff at those levels. It does include a standardisation of our communications and our letters with family awaiting and in services from the point of receipt of that referral, and also communicating back to the referrer. We know at this time communication is ad hoc, it's not consistent, and that will be changed. We are currently onboarding onto the National Children's Team a communication resource to help us deliver that, and we expect that she will be on board in August. Meanwhile, our working group is developing a guide for communicating effectively with families. We hope to have that finished in July, and we will run a webinar with staff of CD&Ts on implementing this guide and on the communications action plan and supports and development in September. Our PDS website is currently going through phase 1 of a review, and that's on target for delivery in November. It will be merged in Q1 of next year with the new online resources hub that Ben will talk to you about shortly. Our second 6-monthly webinar, you'll now hopefully have gotten your save the date for all FRG members, takes place on July 2nd. You provided us with feedback at the end of our first webinar in January, which I gratefully received, and we will use that to inform the development of our second webinar. We will do as we did the last time. We will continue to run until we have the last question answered on the day. So I look forward to seeing you then. The GNU review at the Family Forums and FRG was completed in April, and the HSE's draft action plan you'll have received a couple of weeks ago. I thank you very much for all of you who fed back on the action plan, and the working group is now currently considering all of that. It will be finalised for the Service Improvement Programme Board to meet today, and once that's signed off, then we will begin implementing it straight away. Just to say, we have shortened its timeline for delivery now. It will be delivered completely. The 10 robust and heavy actions will be completed by the end of March 2026. Our FRG 6-monthly survey.
Sorry, Anne, I'm going to have to cut in on you there because the webinar is actually, it's going to run out of clock time. I'm sorry, Anne, and I don't want to lose the benefit of being able to conclude for the parents. So if you could just maybe wrap that there, please.
That's it. It's done, Bernard. Thank you.
Thanks, Anne. I'm going to hand over very briefly to Ben. Just there was a lot of feedback regarding our need for communication. So Ben, just briefly, can you give us an overview of what's happening there? Thank you.
So developing a single place for evidence-informed health, wellbeing and services information and resources online. January, we published improved services information. And as Anne said, the reviewed and extended advice support for parents will start to be published in September. The new information and resource service will be available from November. The initial work is looking at existing information materials and pulling those together into one single place. The resource hub will support parents and carers to access the information they need. It will reduce duplication and inconsistency across multiple CDNT websites, apply best practice in accessibility and content design, and importantly, it will be integrated with My Child on the hse.ie website and also available through the HSE Health app. And very importantly, it will be actively maintained and continuously improved based on feedback from parents, carers, and children. That's it from me.
Thank you so much, Ben. We had a video that we had from St. Gabriel's. So what I'm going to do is I'm going to share, it's a 5-minute video, so I'm going to share it with all the participants on the call. And we have Teresa, who's the CEO of St. Gabriel's, and we have Aileen. We're not going to play the video, Laura. We're just going to ask them just to talk to the initiative. And it's about just the importance of us all working in collaboration with our Section 38 and 39s. That's okay. I'll hand over to Teresa and Aileen. Thank you.
Thank you. So my name is Aileen Shinners and I'm the CDNM with the St. Gabriel's Foundation South City CDNT. I'll keep this very brief. So we're a Section 39 organisation, not for profit, and we're governed by our board of directors. We have 2 Children's Disability Network teams based in Limerick, as well as 2 social enterprises, hydrotherapy pool, orthotics. We also have a respite house and we have a school on site with one of our CDNTs. I'll go to the next slide, please. So this is just an overview of the catchment area. So our 2 CDNTs cover, I suppose, South Limerick, so South Limerick City and South Limerick County. And I'll go on to the next slide. And I suppose I'll actually skip on to the next slide if that's okay. So South City team is the one that we're referring to today. It was established in January 2022, and it was established in an area of Limerick City with one of the highest rates of social deprivation nationally and a higher than average rate of disability as well. So I suppose the CDNT was developed to align with community health networks in primary care, and it was closely developed to align with the 12 principles of PDS. We're a really small interdisciplinary team with a rapidly growing caseload, I suppose, in a really complex area. I skip on to the next slide, please. So when we were looking for, I suppose, the best place to develop a building for the team, we looked really closely at South Hill. And I suppose the reason being South Hill is the ideal location because it's right in the heart of the community of Health Network 7, and that's how it's described as the people who live there. The majority of families accessing support from our CDNT work or live there or live in very close proximity to it. And I suppose in lining up with our 12 principles, it's really easily accessible. It's on an active bus route, and there's lots of parking there. So in 2023, we acquired a building in that catchment area. It's an old primary school. And I suppose it's from there then we were looking to develop it. And this just gives you kind of a timeline of how that came about. So initially, before the establishment of the team, we were looking at available spaces with the HSE. In 2022, when the team was established, that ongoing engagement, we identified the premises in 2023 with support from the diocese. And then in 24, we secured Government Council of Philanthropy funding. And as of 2025, we now have that HSE funding approved. So I suppose we're hoping to start the building in the coming weeks. And as was said, you know, in 2027, it'll be up and running. And I suppose just to mention one very last point in relation to where it's located, it's co-located with a huge primary care centre in South Hill. We also have Bernardo's, South Hill Hub, Family Resource Centre, and lots of schools close by. So I suppose that's just, you know, the interagency working within the community. That's a really vital part of what we're trying to do. And I'm conscious of time, so I can end it there. And hopefully you'll get to see the video as well, which will give you more of an insight.
Aileen, thank you so much for that. And it's a real initiative where everyone has come together in partnership and the location is really, really positive. I'm going to now at this point hand over to Bernard. There was a number of queries that came in from department that related more to the Department of Education and the Department of Social Protection. So I'll ask Bernard just to address those.
Right, thanks everybody, and apologies. I know people's time, particularly parents, are on a very significant time pressure all of the time, so I won't over burden it. I think most of it has been said, but I want to give you just the key reflections from my perspective around some of the decisions I've made and some of the decisions I intend to pursue, and some of those you'll have heard tacitly in different ways on the call. So the first thing is the single front door for children. I want to thank the guys for presenting that, Niamh and colleagues, and indeed for the work they've done, as it does require a combined putting together of potentially different methods and pathways into a very simple and understanding thing. But there are two things I heard from parents, and there are two things I intend to have finalised by about October. I suspect you won't see the impact of it probably until the start of next year, but I've said it's no later than the start of next year, and I hope ahead of that. And that is that there is a single front door for referring children to HSE community services. Doesn't matter if it's primary care, doesn't matter if it's CAMHS, doesn't matter if it's disabilities. And it doesn't actually matter if it's even not sure or known at the time of referral of exactly what's needed. That's our job. It's not the job of parents or other professionals to be filling out reams and reams of forms to be told the referral was to the wrong place and have to start again. So that's going to go. That's what a simple front door means. And one of the things I'm going to be doing is, while respecting clinical and professional appropriateness around how that's done, I'm not going to allow that to be dragged back into any type of bureaucratic space where I'm told there's 40 clinical reasons why something can't be done. It can be done, and that's what we're going to do. So that's the first thing. The second thing is, I was particularly struck in some areas by the benefit of a potential of a key worker system and a coordinating system. And while when a child might be working, or a family might be working with a multidisciplinary team like a CDNT, there may be a key worker, as in the obvious professional who has the dominant role. I think what families reflected to me was the need for a coordinating function or role across teams with high volumes of children. People talked about the benefit of perhaps social care workers or others doing that. So Aoife and Mary Dorn have talked about the jobs that are going out to the system this year to support that. But I am committed to making sure that we get through the estimates process and that we prioritise that teams and families have an identifiable coordinating reference point that they can go to that can coordinate different aspects of service for them. And that's not just disability service, it is about accessing service. The admin support, people prevailed on me, I think particularly one of the Dublin meetings, people prevailed on me to say that therapists were tied up doing too much admin work and therefore their time was consumed, and if they had admin support they could do more. I'm going to certainly try to advance that. I want to say I'm equally sceptical of anyone thinking there's a simple solution to that. I've been in the health service for almost 38 years and I've seen many admin support initiatives to different clinical groupings in an attempt to create more time to see the public and see children. It doesn't always translate into more time to do that. So I would want to be convinced of it, but I'm certainly committed to attempting to do that. If the evidence works, I'll continue to support that. One of the other things is that the discourse around the whole PTS model and the approach of CDNTs is very encouraging feedback from people, which I was delighted to hear. But there was also significant feedback that there was perhaps too much rigidity in how we apply the policy or how we interpret the policy at different local levels. And so I plan to introduce more flexibility into that in a way that's about us as health professionals responding to the need of a child we see in front of us, rather than trying to make a child fit into our particular book or procedure. And I'm particularly conscious that needs to happen. On the forums, I was delighted to hear the feedback I heard, both good and bad. We will support parents in whatever way they want to collaborate around forums, but I want to be clear, the HSE will not decide how a forum is constructed, who's on it, or what it does. That would be to totally disenfranchise the one thing that parents should control and do control. So I'll be endorsing a very different approach to that. I hope that forums can reach the level around the country of the type that I saw of the experience in Donegal and in the Northwest. The retention Mary Dorn has talked about, and I'm fully engaged with government on trying to identify specific initiatives that would add to the specific retention of professionals in children's disability services. I want to say to you that is not easy to do in a health service, because we also have all of those other professionals in services that are not disability, and there's issues around equity and challenge, but I'm certainly supportive of it. National Disability Authority review that was referenced, I'm anxious to see what that looks like, but I'm not waiting for that to make some of the basic changes we need to make. And as Aoife said, a lot of people said to me around the country that there are different concerns, be it around carers allowance, social welfare, housing, education. Education are doing their own thing, building a therapy service in respect of special schools. I'd be interested to see how that maps out. But I just say to you, I have and I do participate in the Cabinet Committee on Disabilities, and I have made those concerns known, and I continue to make those concerns. So I'm very anxious that we move on with very practical and pragmatic steps rather than trying to rewrite everything and spend too much time rewriting policies. I'm very anxious that we actually now take what we know works and we get on with that. The progress on recruitment you've seen from Mary, it's still not enough, but it is fantastic, and a lot of it has improved in a very short frame of time because Mary is now dedicated fully to the disability sector. And I want to thank her for that work. You will see further progress on that. I suspect, however, with the level of demand we have, we'll have to go way beyond even what we're currently funded for, and that's what the next round of estimates will be about, because obviously the demand is very high. So that's it, Aoife. Thanks very much.
Thanks, everybody. There's been a significant number of questions and queries that have come in through the chat, but I'm conscious of everyone's time. So what I'm going to do is I'm going to collate those questions and actually respond to them, and I'll share that with all the participants. There is some parents who were registered that were unable to attend, so we're going to share this as it's recorded. So thank you again, everyone, for your feedback, and we hope to progress with all actions as discussed today. Thank you very much. Bye now.